Hello again. We're going to be doing some overview about tracheostomy care and trach suctioning in this first video. The actual procedure for trach care will be in a subsequent video. To start with, when we're talking about the tracheostomy and airway in general, we want to make sure that we maintain airway patency, and what that means is making sure that it remains open so that the patient can breathe in oxygen and breathe the carbon dioxide out. So you'll hear us say all the time, ABCs. That's your airway, breathing, and circulation. Your airway issues are going to be a priority over a bunch of other issues. Some things that you need to be aware of with regards to issues could be any number of obstructions that happen in the airway. So it could be something called a mucus plug, where a bunch of mucus gets stuck. Could be in the airway, could be in the actual inner cannula of the tracheostomy. Foreign objects, so think of little kids that are curious and they want to try to eat a penny or something, or maybe the hot dog isn't chopped up small enough and it gets lodged in the airway. Misplacement of the tracheostomy tube. If it's not placed properly, air could be going and causing what they call subcutaneous emphysema. And it kind of is like a bubble wrappy type feeling to that. And then there's also mechanical issues. So maybe the patient has a tumor, whether it's a benign or a cancerous tumor, or soft tissue buildup. So those are some potential causes of obstruction. Prior to needing to suction a patient, we of course want to encourage them to cough and deep breathe, because those are non-invasive measures. Suctioning is very traumatic to the airway. Patients hate it for all of the reasons that it's literally you're sucking air out of their lungs while you're trying to get whatever mucus buildup is going on inside. Some rules of thumb: you always want to have a spare trach at the bedside. So this one is, we call a 6 Shiley. It would be, maybe it's a size 4 or a size 8. It just kind of depends on your patient, the size, and the size of the tracheostomy that they have placed. And in these boxes, of course, this would be all sterile wrapped, but brand new out of the box is going to look like this. So you have your face plate here. There's an obturator which comes in the middle, and this is going to help with insertion. So we keep a spare one at the bedside in case something happens. Usually it's a size smaller one too. So we might have, say, a size 7 in the patient, and we have a 6 at the bedside, just in case the airway becomes dislodged. We could put a new one in the meantime, so that way at least they have an airway. So we would have the obturator in to place it, and then we would have our inner cannula is going to go, this is the outer cannula, and it's going to sit in there. Okay, so then we could put it into the patient if we needed to in an emergency situation. We have an air cuff here, which this is a pilot balloon. And then this cord is where we would inflate the balloon. So in the hospital, a lot of times respiratory therapy is the one that messes with this, but just know, like, regular syringe can attach to it, and we're going to inflate the balloon. See if I can get this to inflate a little bit better. And this is to help prevent the tube from getting dislodged. So it's going to help with securing the tube. Now, there are different types of talking valves out there, just so that you're aware, so that the patient can talk. If we're putting a speaking valve, usually a passy mirror valve, if we're putting that on the end of here, we need to make sure that this balloon is deflated before we put the cap over top of it for the patient. Otherwise, the patient's not going to be able to breathe properly. So that's this. Always have a spare one at the bedside, usually going to be a size smaller than what they have. This is a disposable inner cannula, which probably a vast majority of trachs now have a disposable inner cannula, and that would be a clean procedure to remove the old one with clean gloves, and then we could put the new one right in if this gets too clogged up. Let's see. This is a nasal trumpet, and it is to assist with a nasopharyngeal airway. So it would be placed through the nostril down into the nasopharynx. And if we needed to get in to suction the patient, we could go straight down here and be able to suction. This is a very temporary thing. Not seen too often, but if you work with ENT patients, you might see it. And then unless you're in an ICU or the emergency room, you're probably not going to see an ET tube unless you're, or you have a patient that's on a permanent ventilator. Endotracheal tube. This goes down the airway and sticks out like that, and then it gets hooked up to the ventilator that way. But we're not going to focus much on this since this is more critical care, but just be aware that this is another type of airway that's out there. Let me move my stuff out of the way here. Okay, so let's see. I talked about the non-invasive measures with coughing and deep breathing. As far as respiratory status for our patient, when we walk into a room, especially once we get more seasoned, we can look at a patient and identify if they're having issues with their respiratory, whether it's the rate, the pattern of their breathing, chest expansions. We should see a symmetrical chest expansion. Looking at the mucous membranes, so looking at the lips, the mouth, the tip of the nose, looking at our fingernails and the nail beds, looking for cyanosis, which means that they're not getting the oxygen that they need. Making sure that their trachea is midline. There shouldn't be any tracheal deviation going on. If they have secretions, monitoring to see how thick those secretions are, the color of them, if there's any kind of odor, and then the amount, of course. And then also whether or not they're using the accessory muscles, which are right at the rib cage. So think of you're running, and then you feel those muscles kicking in after you've ran. Those are the accessory muscles. And then looking for any kind of bulges or retractions going on up by the intercostal spaces or the clavicles. So anything that would signify a issue where the patient could be going into respiratory distress, we can pick up on that really quickly. We also look at the vital signs. They could be tachycardic with their heart rate, their SpO2 level, their oxygen level percent. Typically, we like to keep patients around 92 or 93% or higher. The exception would be somebody with maybe COPD, lung cancer, or an advanced lung disease. They might live at like 88 or 89% as their baseline. So the rule of thumb is if they're like less than 92 or 93 or 5% less than what their baseline is, that we would likely just have to do an intervention. Some other signs and symptoms to watch for with your patient. If they're getting agitated, restless, they're very anxious, maybe they have some change in mental status where they're becoming confused, or even becoming lethargic, So they could go either way. They could be hypoxic with the lack of oxygen, or they could become hypercapnic where they have too much CO2 going on. So those are some things to monitor with the patients. Of course, listening to lung sounds as well, looking for those adventitious sounds like crackles, rhonchi, could hear it both on inspiration or expiration. Listening for any gurgling sounds. A lot of times these patients, when they need to be suctioned, you can hear them from the doorway because it's so so raspy, and a lot of times they have that rhonchi going on. Breathing pattern, tachypnic would be a fast, usually above 24 breaths per minute. Bradypnea is on the slower end, less than 12 per minute. Cheyne-Stokes breathing and Kushmal breathing are different patterns of breathing that would signify an issue. Some other things to consider when we're going to be suctioning our patient, we're going to turn our O2 up to 100%, which is 15 liters per minute. For suctioning, which a lot of times is on the same side of the bed, but for here we have it on the opposite. We want to put it, you'll see the yellow range, which is 80 to 120 millimeters of mercury. That's typically where we're going to keep our suctioning at for our patients. Be mindful that if the secretions are very thick, there may be the possibility that you would have to turn it up a little bit higher, but the standard and best practice is 80 to 120. Only suction your patient when necessary. So you might have an order that says every 8 hours and PRN. But if your patient doesn't need to be suctioned, don't suction them, because the more you suction them, the more secretions they're going to produce because of the trauma that we're causing in that airway. We want the pulse ox to be on continuously while we are doing our procedure. And some of these patients might be on a continuous pulse ox anyway, just so you're aware, but you want to have this at the bedside so that you can get a reading while you're doing your procedure. Suctioning is not something that just the respiratory therapist does. Nursing needs to be able to get in there and clear the airway. You can't wait for respiratory therapy, who's covering 3 different floors, to come and take care of your patient who's desatting. So you need to be able to get in there, get down into the airway, clear it so that the patient can recover. Passes should be ideally in 10 seconds or less. Some sources say 15 seconds or less. The shorter the amount of time we can get down into the airway and back up and replace this oxygen, the better. After you complete a pass, you want to put the trach collar right back on the patient immediately so that they can start to recover. It's going to take them a moment or two to recover because you've just suctioned secretions and they have like no air reserve. So we need them to recover. And then try to limit the suctioning to 3 passes or less. Again, the increase in suctioning can increase the amount of secretions. All right. Excuse me. For the actual suctioning procedure, you'll need a stethoscope. You would need a pulse ox for your patient. You'll need either sterile water or normal saline. We would want to make sure it's not expired. And depending on your facility's policy, maybe it's a one-time use and then you get rid of it. Or maybe it's something you label and it has to be within 24 hours that you use. So it should have the date, time, and initials. And if it's been over 24 hours, we discard it. Or if your facility says one and done, then you just discard it when you're done. You'll need a suction catheter kit, and yours might look a little bit differently in your tote, but typically you're going to use a 10 to 12 French for this. And in your kit, there's a little basin that gets used for the saline or the sterile water. There's a pair of gloves, and just like some of the other sterile procedures we talked about, if you want to use whatever size you need for the clinical setting, like I wear a 7.5, I might bring that in with me, but gloves do come in it. And then you have your suction catheter, and this one's a 10 French. So with the trach catheters, the bigger the number French, the larger the size of the catheter. And then this is where we are going to regulate our suction with the suction chimney. So when we want to apply suction, we can put our finger over top of it. To release suction, we keep our finger off. Okay. If for some reason you have a package that does not include a basin, you could always use this, the inside of the container, as your basin. Alright, so I have my order. It says that I can suction the patient every 8 hours or as needed. I had been doing my rounding and I can audibly hear that Ms. Johnson needs to be suctioned. From the airway, I go in, I check on her, and I notice that she has a pulse ox of 89%, and she has this trach collar on. And what this does is this corrugated tubing gets connected to a humidifier and the oxygen. And we'll say for this example, she's on a 30% trach collar, and maybe that's like 5 liters of oxygen. Okay, so we have that. We have our supplies. We go in, introduce ourselves, and let Miss Mary Jean know that we're going to do a suction. We can hear that she sounds gurgly, some rhonchi going on. But I just have my clean hands. I put the pulse ox on her. I'm going to take a listen to her lungs. I can audibly hear her from the doorway, so I'm expecting I'm going to hear some adventitious sounds. But I'm going to listen to my 5 pairs on the front. And I do identify that she has some rhonchi going on. So I need to get in there and suction her. I'm going to turn my oxygen up to 15 liters per minute at 100%. And then I'm going to come over and I'm going to turn my suction onto regular. And I'm going to put it at 80 to 120 millimeters of mercury. I'm going to bring my tubing over so I have it readily available for her. She's at a 30-degree angle. A lot of these patients will be roughly 30 degrees. And if I need to, I could take the pillow out. And that's just going to help to hyperextend her neck a little bit. So she's getting pre-oxygenated with that 100% of oxygen for her. The pulse ox is on for the entire procedure. If you want to, you could put like a towel or a Chuck's pad over the chest. When we go down to suction, it is going to stimulate coughing. So you could have sputum flying out. You might want a face mask or goggles or a face shield to protect your face as well. So don't lean over your patient like this because stuff's going to come back out at you. Okay. Okie doke. Now we're going to set up our field. And again, remembering we're not dropping our hands below the waist or anything like that. I am going to open my catheter. Gently reach in and get my box. I want to touch it from the sides here. I don't want to touch the inside. And I'm going to make sure that this is not expired and it's within whatever the range the facility says. We'll say this is a brand new bottle. It's not expired. It's sterile water. And I'm going to put my date, time, and initials on it so that for the rest of the day, the policy is it's good for 24 hours. We're going to use that. I can put the lid cap up and I will pour. Okay. And you're going to fill the whole reservoir up because you're going to need to clear that suction catheter, especially if they have a copious amount of secretions. If I want to use these gloves, I can. I'm going to use my 7.5s that I prefer to use. Mary Jean's hanging in there. Let me get my stuff to stay. And put my gloves on. so I've got my sterile gloves on. I'm going to get my catheter ready. So right now both hands are still sterile, but my non-dominant is going to become non-sterile. And what I'm going to do is I'm going to apply a little bit of pressure here to make sure my suction's working before I attach my catheter. And it's working. So I'm going to apply this. See, I'm not letting my sterile hand go below this chimney here. Okay, so this is connected. Now I'm going to just make sure that my tubing functions. And it's working. I'm going to move my trach collar to a blow-by position. And remember, about 10 or 15 seconds down and back up. We're going to go all the way down until we meet resistance or the patient coughs. And then we're going to back up about 1 or 2 centimeters. If we're meeting resistance, we're likely hitting the carina, which is where the bronchi divide. And then see my hand was not on suction at all while I went down. I'm gonna go back. I can keep my thumb on there the whole time, or I can do intermittently as I come up. I'm gonna curl this around my hand to maintain sterility, just in case I need to do another pass. And I put my oxygen on right away. And while she's recovering, I can clear this tubing out. And I'm gonna give her a moment or two. When we were going down suctioning, she's making all kinds of noise because we're disturbing that airway. We see that her pulse ox is still at 89%, okay? We see that she's still got a little bit of difficulty with her breathing, and we can still audibly hear the secretions. So I'm gonna do another pass. Remember, I said no more than 3 is the recommendation. So this is all clear. I'm gonna remove the collar again to blow by. I'm gonna keep my finger off of the suction while I go down. Again, going all the way down until I meet resistance or the patient coughs. I'm gonna apply suction, come back up, and reapply my collar. I'm keeping this just in case I need to do a 3rd pass on her. Give her a moment to recover. We see now that she's at 96% after that 2nd pass. She's starting to breathe a little bit easier. We ask her how she's feeling. She gives a head nod or a thumbs up that she's feeling a little bit better. I can go ahead and wrap this into my glove to get rid of it. So we've noted that she had improvement. If she didn't have improvement after that 2nd suction, I could go down a 3rd time. But she has improved. She's at 96%. I'm going to take a listen to her lungs again to see if there's improvement. Patients that have a lot of secretions, you might not get entirely clear, but there should definitely be an improvement. So we take a listen again in those 5 anterior spots. And she sounds less roncorous than she did. She's sitting at the 96% with the full oxygen. We're going to see how she does going back to her baseline of 30% on the trach collar. So I'm going to turn this back down to, what did I say before, 4 or 6 liters. So she's at 30%. Give her a moment to recover. And I'm going to be watching this pulse ox to make sure she's not dipping back down. And after a moment or so, her breathing is more relaxed. We'll say that she's at 95% with her trach collar at 30%. And her color looks fine. She looks more comfortable. We've got her pillow back. We're going to make sure that she is in a safe position. If we want, we can turn the suction off. A lot of times we put a yankar on the end of this to help protect the end of it. In the hospital setting, especially if they're requiring frequent suctioning, we just leave the suction on so that if we need to get in there and unblock that airway, we already have the suction on and going. But as far as test out, if you wanted to verbalize that you would turn the suction off, that is fine. And then you would go through and document your procedure after you make sure your patient is safe and comfortable. And that is it for the suction portion of it. The separate video is going to be solely on trach care. Okay.